the concept of tonight is really just about basic concepts. My hopes are is we can kind of just work on kind of keeping everything simple and practical. So when we see a patient in our office, we're like, okay, I'm not going to get scared of this. I can handle this. So general concepts, and if you don't mind, I'm going to introduce you to a little bit of imaging and things like that as we go through. So kind of looking, this is an example of an MRI, and probably the simple way, and whenever we do it, we always look at kind of the same thing every time. So you start with a sequence, and that sequence will be is we always look for the little circle, and the little circle is, the little circle is the opening to the ear. The next thing we look at is, and remember the MRI is kind of the opposite or a negative of the of a CAT scan or a regular X-ray. So whatever shows up black is very dense, converts to a CT scan or a cone beam CT scan, that hard calcified tissue shows up light. So this of the jaw joint is the fossa, the hard bone of the fossa. We have our condyle here, and everybody's like, okay, where's the disc? We always want to look at, exciting, like, okay, where's the disc? And I would say that before you start looking for it, always go back and just look at your regular reference points and then go from there. So when we look at it, again, external auditory canal, sideways S, which is the fossa on the articular eminence, and the articular eminence has bone marrow inside of it, shows up white on an MRI because bone marrow has a lot of fat in it. And then basically we look at the condyle, and we look for a nice smooth outer layer, which is cortical bone. And I typically describe the condyle kind of like a chicken bone, hard outer layer of chicken bone with the bone marrow on the inside. So then when we start looking at, ideally in a normal joint situation, the posterior aspect of the disc or the meniscus should be at 12 o'clock on the face of a clock. So if we look at it, and this is a normal joint, which is like so incredibly hard to find. So I have this image, and I kind of save it and share it with friends because it's such a special image. But the thought is we see the posterior facet or the posterior aspect, the central medial zone that gets very thin, and the anterior facet. So basically what this says is this meniscus at 12 o'clock, the posterior facet, it's got good shape, morphology, and length. And when we look at the condyle is relatively centered in the fossa. The other thing to look at is the shape of the fossa and the shape of the condyle are non-congruent. They're not the same, which is good. So we would say a normal joint should not look like it fits together versus an abnormal joint, which we'll look at some more. So, and then when we open, you remember the inferior head of lateral pterygoid muscle attaches to the fovea below the condylar head. And when we open our mouth, the lateral pterygoid muscle contracts and the condyle slides down the eminence. And ideally the meniscus, the disc, should go with it in this perfect kind of beautiful bow tie, classically defined shape. So kind of I describe the meniscus as kind of being riding like a sled that the condyle rides with to go down the eminence. So by the way, any questions along the way, please put in, please use the chat room, and we'll, at the end of this, we'll be able to answer. So kind of looking at joint mechanics, and I guess I'm going to simplify the joint, TM joint issues. Either we have mechanical or we have structural problems. And a lot of times we get kind of stuck on, oh no, what does all that really mean? So if we can really start saying mechanics and structure, I think we can start to simplify and work through some really challenging, potentially challenging case presentations or patient presentations. So real quickly, kind of looking at what happens when we clinch our teeth together. So force clenched, and we'll have discussions about force clenched with the meniscus in place and then force clenched with the meniscus out of place. And we'll talk about the kind of the natures of that. But when we look at this, if you kind of look at, this is an MRI on the bottom, and then on the top is a cone beam CT scan. And if you start to think about it, you start to be able to see that the shape, like you can kind of make out with the shape of the meniscus within this space. So you see the thick area, central medial zone, and anterior facet. And then in the coronal view, which is looking straight on the patient, this being buccal or lateral, and this being the medial, that we can kind of tell when the meniscus is in place. It's that dark signal on the cone beam CT scan that is a beautiful, smooth, very even joint space. So we're going to use that as a little clue as, is the meniscus in place or out of place, by looking at the shapes on the cone beam CT scan, because in reality, that's what most of us are going to have at our access. Challenges of getting a good MRI even in big cities is still a challenge. So so I'm going to really kind of ask us to really focus in on the tools that we have and do our best to use those. So kind of moving on. So we start thinking about kind of joint mechanics. So this is kind of two examples. We have on the left this is a condyle, excuse my fifth grade version of this. Drawing in Keynote is kind of always interesting, but I thought hopefully it makes sense to you. So the thought would be is we have our condyle with the meniscus evenly displaced, evenly positioned on top. And if we clench our teeth, force together with the meniscus in place, that the meniscus kind of cartilage-like, when you compress it, it just kind of pushes back. It's rubbery, so it's kind of a cushion, and it also evenly distributes the forces along the surface of the condyle. So when the meniscus is in place, we can squish really hard, and the resiliency of the cartilage will kind of push back, and no harm, no foul. So when the meniscus slips out of place, we remember the meniscus, and we'll talk about this in a moment, the meniscus slips out of place, the posterior ligament or the retrodiscal tissue now gets pulled over top of it, and now we're functioning on the posterior ligament. And, we all kind of have maybe various different understandings of being on the posterior ligament. So let me clarify something, that the posterior ligament, and going back to the old load testing and things like that, is that in order to load test a joint, we think that if we have pain there, that we're on our posterior ligament or retrodiscal tissues. And just to clarify that, it's not that. So meaning the posterior ligament, it's resilient to a point, but the difference between the posterior ligament and the meniscus is the posterior ligament I describe as kind of like a dense sponge. So when we compress it or we clench our teeth on the posterior ligament, we actually squish into it. And there's a little bit of an effect where you actually kind of squish, and basically what ends up happening, kind of like a sponge, you can squeeze the fluid out of it. With a meniscus, it's a lot harder to squeeze the fluid out of just by the nature of the cartilage. So kind of continuing, so joint mechanics. So basically we start to think about when a joint's not working well. And all of this is hopefully information to help us say, okay, when the disc or the meniscus is out of place, the joint will click. And then ultimately my hopes at the end of our time together will be is that we can tell when we should worry and when we should not worry. So I'll bring all that together. But continuing on is, so when we're functioning on our posterior ligament and we compress the posterior ligament, I'd say that when you squish your teeth together, that the posterior ligament, like a dense sponge, the fluid gets squished out of it. And you imagine if you take a sponge and you squeeze it, what ends up happening is you squeeze all the fluid out of it. And when you release the pressure, the surfaces are kind of stuck together, kind of a hydrostatic pressure. And I affectionately describe it as a sticky bubble gum. So you end up getting this suction cup effect. And if it stays here too long, you get sticky bubble gum between the two surfaces. So that sticky bubble gum is analogous to adhesions or severe joint space adhesions or scar tissue, for lack of a better term. So does that make sense? We squish really hard. When we squish really hard, we squeeze all the fluid out of it. When we're in the posterior ligament, when we squeeze all the fluid out of it, the surfaces get kind of sticky. And when the surfaces get sticky, if they stay that way, then they develop scar tissue or adhesions. So hopefully everybody's got that concept. So in this picture, we have our condyle. Here's our posterior ligament. And then there's a layer of the sticky bubble gum. It's not that big, but just for the sake of discussion. And then again, this is the bony fossa, so of it working. So a couple key points to talk about would be one is that the understanding that with all joints, that the joint or the nutrition to the joint, and remember that inside the joint, all the tissues, there's no blood vessels going to cartilage. And when there's cartilage, when the cartilage is there, there's no blood vessels, so the way it gets its nutrition is by kind of the fluid inside the joint, synovial fluid, which is kind of a plasma filtrate, brings oxygen and sugars into bathe and give the nutrition to the cartilage inside the joint. So going back, so as we move our jaw moves down, we compress the soft tissues lining the joints, which is our synovial tissue. And when the synovial tissue gets squeezed, it squishes out, or synovial fluid gets squished out. So the fact is when we have a joint that's not moving, then the nutrition to the intracapsular, intra-articular tissues doesn't get there. So thinking about that, how long can the cartilage go without nutrition? We think probably weeks to a month or so. But the importance of really making sure that jaw movement is the key. And this is probably not isolated to just our temporomandibular joint, but to all joints. And that's why movement has become such an important part of all of our activities to keep us limber and smooth and comfortable with movement. So key to joint mechanics is keeping it moving. So this is a couple things as a surgeon. I don't want to wire jaws shut. I don't want to immobilize jaws, because how does the structures inside the joint get their nutrition? So basic concept again. So kind of continuing on joint mechanics, if we think about normal movements of jaws, we want to make sure that movements are smooth, have a good velocity, and there's not like a stuttering effect or clunk, 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 or being on a cobblestone street and all the irregularities with movement. It should be all very smooth and fast. So kind of looking at kind of good velocity, good smooth movement, range of motion, and then also looking at muscle coordination. And if you don't mind, this is my surgical assistant who's got a lot of parafunction. And if you watched her move, you see her jaw kind of jiggle a little bit, which really says she's got kind of muscles that are a little tired. She works for me, so I'm a little stressful, of course. So she has a reason for that. But also on a sideline, I also do Botox for her to help calm down her muscles, because when they're calm, they run so smoothly. When they're tired and fatigued, there's a lot of jerkiness and quivering. So good movement, good velocity, smooth movements with good coordinated movements are all kind of signs of a good, healthy joint. So now kind of thinking about it, the joint mechanics, the integrity of the ligament. So imagine you have your condyle and the meniscus being held in place, the blue being the meniscus or disc, and the green are the ligaments. So we have a lateral and distal medial ligament. So the best way I can describe it is if you imagine your hand being a fist, the condyle sits on top of it, and then your fingers and your thumb on top are kind of the chin straps, so like a helmet. You have the outer chin strap, the lateral discal ligament, the inner medial discal ligament, and it holds the meniscus to the condylar head. So when we move, it moves as one unit. It translates down very smoothly. But what happens is that if the ligaments get stretched, then what ends up happening, the meniscus displaces. And this represents kind of a couple things happen, and I'm going to play that again. So watch what happens when the meniscus happens. The ligaments get stretched, which is the first process. And we usually think that there's probably trauma, some benign trauma. It doesn't have to be a big trauma. But if you imagine getting hit in the chin or bump to the chin, that the condyle moves backwards. And when it moves backwards, the lateral and medial discal ligaments can sometimes get stretched as a result of that. And the ligaments kind of like elastic, an elastic being, you can stretch it to a certain point, but once you overstretch it, now you've permanently deformed it. You've lost its elasticity. And what ends up happening is once the ligaments are loose, you got the slippery object, or in between two hard objects, between the fossa and the condyle. And then if you happen to compress your teeth, I call that kind of the watermelon seed effect. The meniscus starts getting slippery, and the ligaments will, because they're loose, the meniscus starts to kind of slip a little bit. So basically that's the process. Then once the ligaments get a little loose, they get a little looser, a little looser, a little looser over time until we have kind of a full displacement of the meniscus. But when we look at our picture, and let me do this one more time, now look at our condyle. So when our meniscus slips out of place, what happens to our condyle? So when the meniscus is in place, the condyle is pretty centered in the fossa. But when the meniscus slips out of place, we get a distalized condyle. And this goes against some of our paradigms because we usually think that a distalized contact is related to a distalized condyle represent evidence of a distalizing contact or a restricted curve, restricted envelope of function that pushes the condyle back. And I'm going to say that a distalized condyle represents an earlier displacement of the meniscus, and the meniscus displaces anteriorly, the condyle slips posterior, we end up distal in the fossa. So there's a condition that some of our patients might have, and I have this EDS, and EDS stands for Ehlers-Danlos syndrome. And this is a syndrome where people have a collagen disorder where they have hypermobility. With the hypermobility, they're more prone to joint injuries. So just to, we will see that with our patients if you start asking about it. The other will be is some patients just have a propensity for more hypermobility. So they may not have a Ehlers-Danlos syndrome diagnosis, but what they will have is looser ligaments. And probably when you ask them their questions, do they roll their ankles? Do they do other things? Which shows that when ligaments aren't rigid and tight, the joint gets sloppy or it gets moving, and we end up just injuring them more often. So someone that's rolled their ankles, had surgery multiple times at a young age, we start thinking maybe they are predisposed to kind of more a hypermobility system. And therefore joints get injured more easily. So now the understanding I made reference to this is, so when the meniscus displaces anteriorly, the posterior ligament or retrodiscal tissue gets pulled over top of the condylar head. So now we're functioning on the posterior ligament. So going back to kind of the beginning, the posterior ligament, we've been taught that when we're loading the posterior ligament, it hurts. So realistically, my experience has been is that the posterior ligament is highly adaptive, and because it's such a slow process, it actually functions pretty well. So, but the understanding is we have an anterior displaced meniscus, the posterior ligament or retrodiscal tissue gets pulled over top of it, and now that becomes our interpositional material that we're functioning on. When we open, we slide down the eminence, and if there's going to be if the meniscus is in the way, we'll click and get on it. So again, we'll slide down and get on top of the meniscus is when we'll get a click. So posterior ligament, just to take home message, is highly adaptable. You're really not concerned that there's a problem with it being on the posterior ligament can be painful. So just want to have that understanding, and that might be a paradigm shift for a lot of people. But experience has been that majority of our patients that go through hygiene, a good number of our patients going through hygiene will have an anterior displaced meniscus or disc, and they're functional in their posterior ligament, and they're happy and they don't know they have any problems. So usually the ones that we're going to talk about are the troublemakers, the ones that are not doing so well. Because most of them, no pain, no harm, no foul, then we're just going to assume that they're fine. And we'll talk about who are the ones to worry about and who are the ones not to worry about. So, okay. So a couple things. I like to describe this as a life of a displaced meniscus. So what I mean by that is when a meniscus displaces or a disc displaces, it usually starts off as this kind of beautiful shape, biconcave disc. It's got a nice shape to it. It's thick, thin, and thick, and it's got good length to it. So it has a shape and morphology, and it has good length. But then when it's been displaced for a period of time, what ends up happening, it starts to get kind of changed in its shape. And because when the condyle slides down the eminence and bumps up against the meniscus, it starts to get kind of accordioned. And this image is supposed to represent the kind of the accordion fashion of the meniscus. And as it does that, the posterior ligaments get stretched more and more and more until eventually, the meniscus is pretty far out of place. It starts to kind of get wherever these little corrugations are, we start to get scarring of them. And when there's scarring of it, we start to get this shape that starts to get more kind of amorphous, lacking normal morphology or shape, and just kind of, I sometimes start to describe it as a blob. There's no real, it's no distinct shape. And then when the meniscus gets further along in its process, it gets pushed further and further forward. There's a ligament on the front edge, and as the ligament starts to gain tension, what ends up happening, it kind of pulls that front end around, and we start to get this kind of U-shaped meniscus. And then with more and more time, it kind of folds on itself. And I call this a watermelon seed, or it just basically shrunk in size. It has no more morphology, and it's usually pushed pretty far out of the way. And I would probably say this sequence probably can take up to 30 years to occur. Again, everybody's a little different. So the life of a displaced meniscus. So not a bad life, just as long as it doesn't get in the way periodically. So now let's start talking about our troublemakers. Our troublemakers are the ones that basically the meniscus displaces. And if we think about, again, if we compress our posterior ligament, we clench our teeth together, and we squeeze all the fluid out of the posterior ligament, and now we get that sticky layer. The sticky bubble gum is in the red image. And again, it's thicker than normal. Please, it's not that thick, but just for the sake of diagrams. So now what happens is if you imagine that the sticky bubble gum that is lining the fossa and lining the top of the retrodiscal tissues or the posterior ligament, that every time we move our jaw, there's friction kind of being created. So if we think about it, so the friction, number one is, normally we like a normal joint, which is we have a layer of bone, we have a fibrocartilage layer, we have a layer of fluid or synovial fluid, we have our meniscus. On the undersurface, we have a layer of synovial fluid, and we have our condylar head. So layers of cartilages, 3 layers of cartilages with fluid in between, that slides extremely, the slide coefficient's extremely low. The friction is very low. It moves quickly. So they describe it as 5 times slipperier than ice. So, and muscles like smoothness. We know that when we do our splints, the smoother we can get them, the smoother the movements, the happier muscles are. So with that said is, if we imagine that we have sticky bubble gum in our joint, and every time we move our jaw, there's friction with movement. So our brain's going to describe that or recognize that as restriction movement. It's not smooth, so it's harder to move it. And when that occurs, what ends up happening is muscles tend to tense up a little bit because something's not quite right. And I kind of describe that as, when things aren't smooth, it's kind of like when it freshly snows and we step out the front door, we step on the snow. Before we step on the snow, what do? We kind of tense up. And I sense that kind of same thing. When things aren't smooth, the same idea is that we end up kind of smoothing, we end up kind of tensing the muscles. So on a low level, may not be perceivable to some patients, but it might represent how they move their jaw. So even though they can move and they can translate really well, but they're having troubles because there's friction on movement, and the brain perceives that as that's not moving smoothly. So then the muscles kind of tense up and kind of protect it. So I hope that concept makes sense. So do me a favor. I know some people have some questions. Please put them in the chat room, and I promise I'll end 10 minutes early and do my best to address them. So thank you. So kind of continuing is, so when we have this friction, we slide down, and it's just not sliding as smoothly as it might. So we talked about when we have increased resistance, then we have increased muscle guarding at the same time. So muscle guarding is kind of like when it's not smooth, our muscles kind of tense up. And if we think about, if we have a tense muscle, and this goes back to our biochemistry in dental school, is we activate the Krebs cycle. When a muscle is in sustained contraction, the glucose metabolism now becomes anaerobic, and their anaerobic respiration or metabolism, the end product is lactic acid, which kind of builds up in the muscles. So we have tension. So some of us might describe that as occlusal muscle. And then I'm also going to say, well, but the joint can have a part in this, meaning the muscles are now stabilizing to make sure, or to help limit the movement of that surface that's not smooth. So friction leads to impaired kind of movement, which leads to muscle tension. So, and then kind of continuing, the understanding is if you rub your hands together or knuckles together enough, they're going to get warm. And when they get warm, that's analogous to inflammation. So we have a joint that has some sticky bubble gum in it, and we're moving our jaw, we're talking to our patients, we're yawning, we're doing other things, we have some lunch. Basically, every time we move our jaw, there's friction. And if the more we do it, the more friction there is. So typically what patients will describe that is, I'm okay in the morning, but when by the end of the day, I do have achiness. And then we might think, well, is it muscular? Or is it joint? So a lot of times the way people represent or describe things is, I hurt here or I hurt here. And the two will be is when I hurt here, I'm going to say generalized muscle. If I hurt here, it's joint. And then now the tricky part is it can be both. So where we will talk a little bit about our occlusal muscle disorders and those that have a corresponding or also have a joint issue as well. So kind of continuing. So kind of the understanding is within our picture, if you imagine we have our fossa, the red being the sticky layer, the green being our posterior ligament. And if we get inflammation, so we have friction in the superior joint space, now friction leads to inflammation of the posterior ligament. And if we look at our posterior ligament, as it swells, take a look what happens to our teeth. So let me go back real quick. So the thought would be is if we get swelling within our posterior ligament, what it does is it pushes a condyle down and forward. And as it goes down and forward, we see what happens to our occlusion. So here's how the story usually goes is you have a patient come in, they wake up one morning, they can't get their back teeth together. So, and they feel like they're hitting their front teeth first. And here's another little pearl is, say it's my right jaw joint that's inflamed. So when it swells inside the joint, the posterior ligament swells, my mandible is going to go down and to the left. And a lot of times what people is going to complain, I can't get my back right teeth together and I hit my left front corner first. And it basically, because of the swelling within the joint, we think about that. So here's kind of the take home on that is someone comes in, they feel like I'm hitting hard on their front tooth, they're not touching their back teeth. Rather than equilibrating the anterior, I'm going to think that there's a problem on the anterior where the premature contact is, I don't want to equilibrate that because I'm thinking it's a transient event because of the swelling within the joint. So I hope that makes sense. So we get swelling in our right joint, the condyle gets pushed down and forward, and our mandible kind of goes diagonally, and we end up with premature contacts on the opposite corner and difficulty getting their posterior teeth together. And then when you ask them to try and squeeze their teeth together, what ends up happening, they feel tension or pain here, not here, but here. So little clues along the way. So the other is kind of an understanding, and again, just general concepts. So if we've been functional in the posterior ligaments, so say the story goes, my jaw started clicking in my high school years. In my 20s, it clicked less, and then it kind of may or may not have clicked for a while. But what happens is, as long as we're functional in that posterior ligament, the posterior ligament starts off as being thick. So we have a real good thickness here. But I describe your posterior ligament kind of like your favorite pair of jeans, and meaning that as you wear them, the longer you wear them, then we eventually start to thin out the posterior ligament. So here's another little take home. So if we look at the height of our condyle relative to the thickness of our joint space, as we thin out our joint space, our ramus gets shorter. So I hope that makes sense. So basically the condyle seats more in the fossa. As it seats more in the fossa, the ramus gets shorter. So with that in mind is, if we take that to the next level is as we lose height, then we start to have changes in our occlusion. So the thought would be is when we have changes in our occlusion, we basically, because of it, we end up starting to get more posterior prematurities. So on the same side, we start to hit where we went from having contact to our canine forward, we start to move to first premolar, second premolar, and eventually onto our molars. So, but that happens very slowly. So kind of as things happen slowly, we're going to talk about some nice adaptation that it can occur. So just want understanding that it does wear over time. But I'm still going to say still not a doom and gloom situation, meaning that over time, things are adapting as long as it's occurring slowly, and I'll bring that point home in a moment. So the other concept I like to talk about is whenever we have an injured body part. So say we have inflammation in our jaw joint, a common associated symptom is going to be my neck hurts. So, and let me explain that. So, and probably the best way I can describe it is using this picture. If my elbow hurts, what do I tend to do? I tend to keep it close and high. By keeping it close and high, my elbow starts to feel better because I'm babying it, but now my neck and shoulders start to hurt. And we wonder, well, my elbow hurts, but why is my neck and shoulders? So I'm going to use the term guarding, muscular guarding. So now, as a way to protect an injured body part, we go into a sustained contraction where the muscles are tense, and now lactic acid builds up and the muscle goes into a kind of a anaerobic respiration chronically. That, lactic acid makes muscles irritable muscles spasm, and they wax and wane. So it can be very uncomfortable over time. So the term of sore joint, muscles get sore because they're protecting an injured body part. The term guarding. So going on, so the thought of joint structure. So we described joint movement, joint mechanics, and joint structure. So joint mechanics is joints should run smoothly. If they don't move smoothly because a meniscus or disc is in the place and we click, then we're going to have potentially muscle-related issues or not. So we'll talk about that. So, but looking at joint structure now. So while our meniscus is in place, basically the meniscus is resilient and it has a very set dimension. It's very hard to change the meniscus, and some people can do it. It's really profound, long-standing clinchers can do it really well. They just thin it out. but most of us are going to kind of keep it bounces back. So if we think about it, not a lot of changes occur in our occlusion if the meniscus is in place. But what if the meniscus is out of place? We have the thickness of the posterior ligament that can thin out, and the potential for unstable occlusion. So here's kind of an example. So what happens is our posterior ligament over time kind of thins, and as it thins, our condyle moves up, and as it moves up, we get occlusal changes. So that can be the thickness of the soft tissues. It can also be the shape of the bone, which we'll talk about. So kind of another point I'd like to bring up is that without the meniscus in place, and if we think about the shape of our condyle, the shape of our fossa, the condyle is kind of round, the fossa is kind of flat. So what happens is now the bone, because there's ligament in between it and ligament is compressible. So if we push really hard, the most prominent part of bone right here is going to touch down on against the fossa. So what happens in our body is all about adapting, and adapting meaning we don't like balancing on one foot. We don't like to have a small area of force distribution. We really want a broad area of force distribution. So what we've noticed is what happens on bone when the meniscus is out of place. Now the bone loads differently, and as an adaptation, the bone's going to kind of change shape. So what it's going to do is it's going to resorb a little bit, flatten out, and now we have this really broad zone of load distribution, which is structurally super cool because now that can really sustain a lot of load and force, but there's a little bit of a price to pay for it. As we've lost bone, we end up losing a little bit of posterior ramus height, and subsequently our occlusion transfers from an anterior based occlusion more and starts to move for the premature contacts posteriorly. So a change in the occlusion. Hope that makes sense to everybody. So this also might be is when you look at cone beam CT scans and we see flattening of the condyle, we see beaking or other things we see on a cone beam CT scan. I'm like, oh no, that's horrible, because that looks like osteoarthritis by definition. I'm going to say that's adaptation. Your body is making itself flat to distribute load over a broader area. So structurally more stable. So let's talk about getting into our cases of patients that are going to worry us or not worry us. So the thought would be so say this process, we have our posterior ligament that thins out, and as it thins out, the bone loads, it starts to remodel and adapt itself so that there's a broader load zone. If all that happens really slowly, then we typically don't see a change in the occlusion. Teeth under pressure are going to adapt themselves so that the occlusion kind of stays. So if we have a premature contact with light forces, that tooth's going to move out of position. So with that in mind, we'll get a subtle change. So as an example of that, the bone kind of levels. So kind of looking at kind of examples of kind of changes, and good. Looks like we have someone with their hand. George, you want to say something? We can ask at the end then, okay? Cool. So kind of looking at the joint. So what happens is when we start to lose bone, what happens is we start here, and this is a cone beam CT scan of somebody that's losing bone in their condyle. And what that means is that look at the cortical bone from here to here. I don't see any cortical bone. But what happens is adaptation is the bone remodels and we reform a cortex around it. So we went from being an unstable situation where we're lacking stable cortical bone to now that's looking something that looks quite stable. So, but again, there's a price to pay for it because it's smaller the condyle is smaller, the volume of the condyle is smaller, and the height of the ramus is smaller as a response to that. So here's kind of examples of somebody on the top. Basically, they lost bone slowly, and they probably lost bone while they were still growing, because look at her occlusal cant. So basically how much longer she is on the right, how much shorter. And this also, when we look at her face, you'll notice a large facial asymmetry as well. But occlusally, we don't see a big bite change. So because everything happened slowly, slow enough, if it was occurring while growth was occurring, we had growth to compensate. If it happened slowly, then we get teeth under load getting depressed and teeth that are coming out of contact erupting into position. So we get adaptation of the alveolus and teeth. Versus somebody that occurred rapidly, we end up with an anterior open bite with only contact on the posterior molars. So one thing about this picture, if we can do, is if we start to look at this view, take a look at how far she is from her canine cuspid to cuspid here on her right side compared to here. So this is kind of important. This little view tells us that she's had changes in her right condyle and the mandible has shifted to her right side. So little clues about, which is our trouble joint. So looking at the occlusion, I kind of describe this as, the occlusion as a tarot card for what's going on in the joints. These are two examples. One that occurs slowly, we get beautiful adaptation of the alveolus, but we end up with a cant in both the maxilla and mandible. Whereas when it occurs very rapidly, the teeth can't adapt fast enough, and we end up with an anterior open bite. So I'm going to say these are good things, kind of looking at, we're going to say we have somebody that's got a joint problem, and we're looking for bite changes as one of our clues for should we worry or should we not worry. So we'll talk a little bit more about that. So kind of quickly, so we started off with the very beginning saying that ideally a normal joint, the condyle and the fossa should not look like they're the same. So look at these joints. So we have a fossa, the condyle, and I would describe them as very congruent. They look like they really match. So I'll tell you that this is a patient whose meniscus is so far out of place. It's a watermelon seed. It's all the way over here. It doesn't function. This is their posterior ligament, which is nice and even. Look how smooth the bone is. So here's somebody who's been functioning on their posterior ligament for a long time. And if I think about it, that's a beautiful, beautiful joint, even though it's abnormal. And some would call this osteoarthritis. I'm going to call this well adapted. It's adapted to the change in anatomy, and again, how beautifully it looks. So if you think about, if this is going to be a case where I'm going to do a quadrant of dentistry, or this is a case that I'm going to do a full mouth reconstruction, or a case for me that I'm going to do orthodontic surgery on, this is beautiful. As long as the joint moves well, mechanically is smooth, and there's no pain or limitation of motion, then I'm going to build whatever I want to build on it. So when I look at a cone beam CT scan, I'm not going to worry about this joint. Of course, I'm going to vet it. I'm going to look at it. I might treat it with some anti-inflammatories as needed, but I'm going to be super careful. But I'm going to be not that worried about it. So, okay. So kind of continuing on, I'm going to go for about 5 more minutes, and then it'll be a pleasure to answer questions for everybody. Kind of looking at, things to say, we're going to see things on our cone beam CT scans, and we're going to say, those look yucky, and really, I'm worried. But let me tell you, this joint, I look at the condyle, looks kind of small, it's round, the joint space is narrow, but the surface is smooth. And I'm going to say the articular surface of the condyle and the articular surface of the fossa are the exact same shape. When we look at the coronal view, which is the one looking straight at the patient, look at this funny shaped condyle, but look how smooth the bone is. Look how even the joint space is, and how broad the area of load is. So I'm going to say this is an absolute gorgeous joint. Not normal, it's osteoarthritis by definition, but I'm going to say we can do whatever we want on these joints because they're stable, mechanically work well, and structurally stable. So the contrast would be is if I see potholes and lots of irregularities in here, I'm going to get a little more worried. I'm going to say, okay, that's a joint I want to work up. I want to get an idea of what's going on with it. And then what I might do is if they're asymptomatic, before I do any major treatment, I'm just going to follow them either with cone beam CT scans, which is probably the best, and see what is the trend. Are they trending towards looking prettier? Or are they trending looking towards bigger potholes and things like that? Unlikely joints that are not symptomatic are very rarely going to be troublemakers, but there's never always, there's never never. So just to talk about that. So, but kind of looking, if you don't mind, thinking about our take-home messages for tonight. And I apologize, I went through that really quick, but basically, I guess my hopes is just to understand how the mechanics and the structure of the joint works, not be afraid of it, and then things don't just happen. And what I mean by that is, if a joint's not moving well mechanically, then it's not getting its nutrition, and therefore then tissues inside the joint can go through hypoxic changes, tissue can die, and we can end up with bone loss and things like that inside the joint. So the importance of keeping the jaw moving is so important, which is my last point. Things to remember, moving your jaw side to side is super important. The purpose of side to side is, if you think about it, and we can all do it, when you move your jaw side to side, you don't apply any compression to the joint. So it's all lateral pterygoid muscle just moving side to side. So you're smoothing over areas, and if there's bumps or irregularities, I'm going to say that smooth, gentle movement is going to remodel, reshape, and also smooth out surfaces. It'll take time, but it's a good thing. So side-to-side movements are always a great thing because you're moving a joint, it's repetitive movement with light forces, and we're going to improve nutrition and smoothing things inside the joint. So the thought would be is when should we worry about clicks? So the thought would be is when we have a click that's associated with locking, that means that they have limited opening. So that's one that says that they click and the click, or they get to the point where my jaw clicked and it hurt, so I stopped opening wide. So that would be somebody that says the joint's gotten in the way, the brain says, I'm not going to let you do it anymore. So the muscles kind of take over and say, okay, I'm going to keep you within a safe zone and only let you move so far. So, and a lot of patients do great with that because they keep themselves out of pain, but it's not so good because now they've gotten themselves into developing new muscle engrams that are limited opening, and they're not getting nutrition to their joint. So not a good thing. The other ones to watch out for are clicks that hurt. So and then my favorite question is, when it clicks, do you get like a zing or a sharp sensation? Then I get a little more concerned about that. Another thing would be a joint that clicked that no longer clicks. And that would be typically with somebody also associated with limited opening. So I woke up one morning, my jaw clicked the day before, now it doesn't click, and now I can't open my mouth as wide. So that's going to be a joint where things are stuck, the meniscus isn't moving, they have sticky bubble gum inside the joint, and that's a joint that's not going to get nutrition if we don't address it. So kind of making sure, and that would probably be, in my hands, the best and quickest thing we can do for somebody is get the joint moving. And that's a procedure called an arthrocentesis, which would be a pleasure to talk to people about. But it's really kind of the saving grace for getting somebody moving quickly, getting the joint back to nutrition. So, and I usually find if we can do that within 4 to 6 weeks is adequate. So the next is the joints that hasn't clicked in years, but then starts to click and now it hurts. So that's somebody that's worn through their posterior ligament, but they've been functional ligament, and eventually they wear through it, and that becomes an acute episode. The other joints, if it's a joint associated with an acute bite change, I can only contact my back teeth, or I can only contact my opposite side front teeth. Swelling versus bone loss in the joint. So two things to kind of look out for. And then the ones not to worry about is a click without limitation, or slow opening, because slow opening means that joint's the mechanically is not running smooth. So if it's open quickly, if you can open quickly, it goes very smoothly, then you're golden. Do what you need to do. A non-painful click. I'm going to say non-painful in the absence of any restriction of movement. Let it roll, and as long as the occlusion looks good, I think you're good. And then long-standing clicks and a stable occlusion. Again, if anything bad is going to happen, we're going to see reduction in speed and range of motion. We're also going to see a bite change. So thank you. I went really quickly over that, but I want to thank everybody. Please, here's my email address. If we don't get questions answered, please feel free to email me, and be an absolute pleasure to answer them.